You're listening to In Network, Nordic's podcast series where we explore healthcare and technology with experts from around the globe.
Hello, and welcome to the In Network podcast feature, Designing for Health. I'm Nordic's Chief Medical Officer, Dr. Craig Joseph.
And I'm Nordic's Head of Thought Leadership, Dr. Jerome Pagani. We recently chatted with Dr. Adam Wright, Professor of Biomedical Informatics and Medicine at Vanderbilt University's Medical Center and Director of the Vanderbilt Clinical Informatics Center.
In today's episode, Dr. Wright discusses why he chose to study biomedical informatics, what it's like to work with a self-developed EHR, and how math often takes a backseat to walking around the hospital and clinic.
He also shares why feedback is essential for optimal design, the history of clinical decision support, and how to sustain projects long after the excitement for them has waned. Let's plug in. Dr. Adam Wright, thanks so much for being here today. It's nice to finally have a real doctor on the podcast.
Absolutely.
Actually, you're our second. We had Dr. Archana Tadone on our last episode.
So our record of having real doctors, which I'm translating apparently for myself and our listening audiences, means a PhD. We have two consecutive real doctors. Am I understanding that correctly, Jerome?
That is correct.
All right. Excellent.
Your words, not mine.
Excellent. So Adam, as a real doctor, I wanted to confirm what I think I heard from you is that ever since you were a young child, when you first got those letter blocks and you were pounding blocks together when you were a toddler, the letters PhD were your favorite. And you always knew from being a very young child that you wanted to be a researcher, an academician. Is that true? Did I hear that correctly?
It was actually HL7. So my first creation with these letter blocks was a valid HL7 2.4 message.
That is amazing. And that was probably before HL7 was even founded as an organization. So prescient.
Not that old.
Prescient. That is amazing. So, all right. Well, maybe you've always been destined for this life. You went to Stanford for undergrad and majored in English.
I did not. Math and computer science, the only true combination of majors.
And apparently my research has not been great here. So, all right. So math and computer science at Stanford. And then you always knew you wanted to be a biomedical informatician. Is that?
I will confess that I had actually never heard of biomedical informatics. So as you said, I studied math and computer science, and I somehow did know that I wanted to go on to graduate school and study a little bit more. And I thought for a long time, should I do a PhD in math or a PhD in computer science? But those both seemed kind of long and hard and theoretical. And so I felt like I wanted to turn to an application of some kind. And I had friends that went into finance or became actuaries. But I was really curious about applications of math and computer science in healthcare or in biology. I had actually never heard of medical informatics. I thought I was going to become an epidemiologist. And then really largely through happenstance, I heard of the field of biomedical informatics. I met this guy, Mark Musin, who's a professor at Stanford in biomedical informatics, and he told me about the field. And I was like, wow, that's what I want to do. That is fascinating. It just struck me that compared to quantitative finance, there were still some kind of low-hanging fruit, some easy problems to solve that needed hard work. It seemed like the problems were interesting. I think I found medicine and physiology and pathophysiology just to be kind of conceptually interesting. And then, most important, there's kind of this pro-social aspect to it. Maybe if I built a good computer application in healthcare, it would help us provide better care to people as opposed to just, make more money, which was appealing to me.
Awesome. So how did you decide on OHSU for your PhD?
So a few reasons. I wanted to work with this guy named Dean Sittig, who I think some of you guys know. And so he was a professor there. I also had family in Portland and really liked Portland. And it just seemed like an interesting place to spend a few years doing a PhD. So that's how I wound up there.
Awesome. And then what is that? Is that a year? I don't really know how PhD schools work. Is that a year and a half?
It varies. I was there for 3 years, which is on the faster side.
Wow.
Yeah, it's somewhere 5 to 7 is more typical. But I kind of made this deal with my committee. I sort of spelled out this thing that I knew I could do, but they didn't think I could do. And then I managed to do it. So we had all agreed that I could graduate if I did it.
That's great. All right. And so after you got your, I guess, the best degree, the real doctor degree.
The real doctor, yes.
Yeah. You moved from one coast to the other coast.
Yes.
And we're at the Brigham. And
yeah.
One thing in our conversations that you've noted earlier was that at the Brigham, you had a developed electronic health record to work with.
Yeah, wild.
Yeah,
Yes.
tell us about that, and
Yeah.
I'm interested to hear how that because while you were there, you moved to one from a major vendor, and
Yes, sir.
I'd love to hear kind of like the pre and post analysis of the.
Yeah. So this is an interesting thing that's been going on in our field of biomedical informatics, right? So many of the initial EHRs and a lot of the early research in electronic health records and decision support was done at places that had developed their own EHR software. So the Brigham, a big teaching hospital in Boston, was one of the earliest adopters of especially computerized physician order entry. And at the time, there was no real good commercial system that you could purchase that would do CPOE with clinical decision support. And so they had made a decision, as had many other kind of leading hospitals, to build their own electronic health record software. And so that was really a fascinating time because we had sort of this notion of physicians and nurses and pharmacists and informaticians who were programmers. You know, you would go to your shift in the ED and then you would pull up the source code for the EHR and make some changes to it. And there was a lot that was good about that, right? If you have the source code to the EHR, you can do whatever you want. You can make any change you want. Your kind of horizons are just limited by your imagination. And it was great. It was an exciting time. We could, build new modalities of decision support. It's also challenging, right? Because anything new we did, we had to program. We didn't just have the ability to kind of configure a new order set. We had to sort of pull up our source code editor and make those changes. And it really worked well for some time. But I think, over time, the commercial EHR vendors were building better products. But the thing that probably really kind of tipped us over the edge, and this happened a number of places, was meaningful use. So suddenly the federal government was giving financial incentives for using an EHR, and that EHR had to be certified. And so we did get our EHR at the Brigham certified, and we did at Vanderbilt here, where I work now too. But increasingly, almost all of our development effort was focused on meeting certification and regulatory requirements, and we could do less and less innovation. And so the problem was, if there was a new round of certification requirements, we had to build all of those just for the benefit of one hospital, whereas a place like Epic, has several hundred customers, and so they could sort of spread the cost of these certification requirements over many different customers. So kind of the writing was on the wall, and it was becoming increasingly clear that we were going to need to transition from a self-developed EHR to a commercial EHR. And over the past decade, so many of the leading institutions, Columbia and partners, so Mass General and the Brigham, the Beth Israel is in the process of a transition. Vanderbilt made a transition from self-developed EHR to Epic. The VA is trying to move with some challenges, as you guys probably know, from their self-developed CPRS system to a commercial system. And there are downsides. I think now we need to sort of work in some ways within the framework that we use Epic here, that Epic has given us. But I've been impressed. I was pessimistic about how much we would be able to configure or customize Epic. And I actually was amazed to discover that we have a lot of control over the system, right? We can build things using Epic's tools. We can create extensions in code. We can even integrate external applications using web services and Smart on Fire. So it's been good.
Adam, do you have some overarching principles for how people and technology should work together in a way that supports that interaction?
Yeah, that's a great question. And, sometimes people ask me, are you just a medical computer scientist? And I say, no, I'm a biomedical informatician. And I actually think that one of the hallmarks of being an informatician is sort of appreciating kind of the people, process, and technology intersections that really make these things work. And I've gotten better at this over the course of my career. I remember early in my career, I would develop these software tools. This is brilliant. I've applied mathematics and computer science. I've developed the perfect software. Then I would sit in my office and no one would use it, or they wouldn't use it the way that I thought they were going to. And I would eventually kind of got so fed up with it that I walked over to the hospital to try to pick a fight and see if I could figure out why they were using my software. And there were people they were sick, they were bleeding, they were having surgery, like all kinds of wild stuff was going on in the hospital. And somehow that occasionally took precedence over using this brilliant software tool that I had developed. And so the more I learned that, the more I realized that I always did better if I spent more time in the hospital, more time talking to doctors and nurses and understanding what they did, and then trying to kind of fit a technology solution into their processes rather than kind of just having my own theory of what their process ought to be. I'll tell you one specific story. We had built this tool to help people prescribe inhalers to kids with asthma. And it was so cool. It was really accurate. We validated it. It was really evidence-based and up to the latest guidelines. And I discovered that people were not prescribing the inhalers I thought that they should use. And so I went over to the clinic and I realized that this doctor, she saw so many patients. She basically just had this like entire hallway of exam rooms. And she would basically walk from kid to kid and like take away one inhaler, give them another inhaler, kind of switch things up. Never logged into the computer during the day. She would just write this like 1 or 2 letter code to herself of what she did to the kid. And then at the end of the day, she would pull up her EHR and she would document all the changes she had made to kids' inhalers over the course of the day. And then my system would pop up all these helpful suggestions like, did you consider albuterol? What about a steroid inhaler? And it was like, these kids were long gone, man. They had gotten a new box of inhalers and they had been home for hours before she even logged into the computer. And so it was my own hubris that made me think that she was going to use the computer in the exam room. No, not at all. And so once I figured that out, I realized that this was needed a completely different approach to providing inhaler-related decision support.
Yeah, it is unfortunate when clinicians don't do what you think that they're going to do.
Correct.
I've certainly been in those shoes, having designed amazing workflows and then finding ways that people bypass those workflows.
Yeah.
It's sad, but it does tell you where you stand. So clearly, observation, meeting with end users, with the clinicians who are at the point of care is important.
Yeah.
And I would presume that when you do that, they tell you things like, hey, this would be so much better if this weren't in alphabetical order, but in order of most frequent things at the top.
Yeah.
Or this color is actually wrong. It doesn't attract my attention. And it would be great if it, and sometimes I think those are key insights. Oftentimes they're key insights, but sometimes they violate principles of design that you're trying to follow. And,
right.
And what they're really telling you is, hey, this would work for me much better, but that person may not represent everyone. And so how do you deal with those kinds of situations?
So I think it's a great question, right? I think that some of us have this tendency to feel like, oh, there was a doctor involved in the design of this, therefore it'll be like clinically accurate and relevant. And often that doctor is, they didn't do residency or they're, a left ankle specialist or something, and this is a primary care tool. So I have found that involving multiple people is valuable, and involving that are actually doing the work is really valuable. We recently worked through a VTE prophylaxis or DVT prophylaxis tool that we had been developing over time. And we had this sort of august group of hematologists and hospital medicine leadership and people from our quality and safety department. But what I realized like partway through the discussion was I actually said, like, has anyone here ever admitted a patient using Epic? Because this stuff shows up at the time of admission. And the answer was no, right? Who does that? The intern does that. Maybe the nocturnist or the hospitalist does that. And so what I found is that involving multiple people and involving, people that are actually doing that work is really, really important. I think, though, you need to be careful. And this is, I think, part of what you're getting at, avoiding design by committee, right? You don't need to pull those people together and have them like, let's just use a whiteboard and just have them, design, the system by themselves. What you really want to do is kind of elicit their requirements and then apply some user design principles to design one or more prototypes and then show those prototypes, get feedback on those prototypes. We do a lot of what I think people call hallway usability testing, right? I'll mock up 3 different versions of a decision support tool, and I'll just get whoever's like at work today, I'll yell down the hall and say, can somebody come look at this and give me some feedback? I have found that people are much more likely to respond well to prototypes than they are to respond to a call to design the things themselves. I think it was Henry Ford had this story where he built the Model T, and he said if I'd asked people what they wanted, they would have said like a faster horse. But he sort of had this insight that there was some alternative there.
Yeah, that's great. And there are, times where you do need a faster horse, but there are other times where you need, visionaries like Henry Ford or Steve Jobs to tell you what you want, and then potentially to iterate, right? Because even though those folks were geniuses, there were times where they created tools that just didn't work for the masses, and you had to kind of go back. And I think that's one of the key things that I'm hearing from you and others who are involved in these kinds of decisions. Like there's no one answer, there's no one rule that fits them all.
I agree. I mean, I thought mightily. I hung on to my BlackBerry forever. I said I'm always always going to have a physical keyboard on my phone. I thought Steve Jobs was nuts to have a soft keyboard. And he was right. But it took me a long time to figure that out. And if I had voted, there would be an iPhone with a keyboard on it.
So you mentioned a little bit about how the EHR has changed over time and how your own approach has changed. What did clinical decision support used to look like?
Yeah. I mean, I think it's evolved a lot, right? So some of the earliest decision support we had was table-based. So we would purchase a list of drug interactions from First Data Bank, and we would sort of implement that. And I would say, why was that the first thing we did? It's because it was the first place where there was a good knowledge base. There wasn't a reliable knowledge base of all the facts of primary care or how to manage a surgical patient, but there was this database you could purchase of drug doses and drug interactions. And so I think that's where we started. And I think we needed that. I mean, obviously, preventing harm from drug interactions or drug allergies is important and valuable. But I would say that over the last few years, there's obviously increasing interest in using machine learning in decision support. So we have a lot of students, especially, that are trying to build predictive models and integrate those into decision support. I can tell you, though, that we have, I think, about 840 decision support tools here at Vanderbilt. And I think probably less than a dozen of them use machine learning. The rest of them use simple logic, decision trees, or guidelines or flowcharts. So I wouldn't count out Boolean logic in the realm of decision support. I would say we have gotten a little bit smarter about workflow. I have increasingly found that using defaults and intelligent presentation of information can be as or more effective than interruptive alerts. I think we kind of got a little carried away with interruptive alerts at some point. And this is not a new idea. If you look back to the 10 commandments of decision support from David Bates and others, they were telling us to avoid stopping and changing directions. But I have personally found that the kind of CDS that is focused on providing the right information at the right time and almost making it seamless to do the right thing has been more effective. I would say if you look at the future, I think we're increasingly seeing externalized decision support tools. So there are standards like CDS hooks that let you build CDS outside of the EHR and integrate it, that let you integrate more complicated user experiences or more advanced models. I think that'll be a big focus. For me, the other thing that's been really important is just increasing the voice of the user. So I have really tried to focus in my career on user feedback and understanding what's working well for people, better monitoring systems to make sure our CDS is achieving its goals. So I think that's the direction we're headed.
I love that conversation about non-interruptive alerts. A study that I can't get rid of was, and I'm not sure if you're familiar with this, from Children's Hospital of Philadelphia. They were trying to decrease the use of albuterol for patients with bronchiolitis. And so they did what I would have done, which is remove albuterol from the list of options in the order set. And so when you opened up the order set for bronchiolitis in the emergency department, you didn't see albuterol, and you could still order it, but you had to slide down to the bottom of the order set and put it in a box and search for it. And it was a little bit onerous, right? It was a little bit difficult to not do the right thing. And what they found was people stopped using the order set.
Yikes.
Right? Because folks said, well, this order set's clearly broken and there's no easy way for me to give feedback. And so I'm just going to just type all the stuff from that box. And the way they fixed this problem was by putting the albuterol, again, the medicine they don't want you to prescribe routinely, back in the order set with a little explainer, a little text box right above saying, hey, you probably shouldn't use this. Research has shown that it really isn't effective. And if you're going to use it, we would really appreciate you ordering a pre and post pulse ox so that we can help you think about evaluating its efficacy. Right. And they achieved the same result of significantly decreased albuterol use by kind of pushing to me, that was a non-interruptive clinical decision support. It's just right there for you to see it. You can still do the thing, but sometimes the logic, at least in my mind, gets turned upside down.
Yeah, I agree. There's a subtle thing that I don't think people always think through is there are some kinds of decision support where I'm helping you remember to do something you want to do. So, you've decided that you want to give pneumococcal vaccination when it's appropriate, and it's just hard to remember who's eligible. Versus I'm using CDS to change your practice. You want to prescribe albuterol. You think it's great. And I'm trying to against your will, kind of force you to not do it by harassing you or making you barrier or make it hard to do. And I really think the way you approach those two things is really important. I think you said probably the most important thing, which is CDS is not the primary tool for getting you to do something you don't want to do, right? Education, like that explainer you put, having a academic detailing or grand rounds where we talk about why we don't use albuterol, having the department chair give an explanation of why he'd prefer you don't use albuterol in bronchiolitis as much. Start with that, and then build in some decision support to push people in that direction. I'll tell you a slightly more cheerful story about modifying order sets. So this is work that David Rubens led at the Brigham. We were noticed that we were ordering much more telemetry than we wanted to order, and much more telemetry than other hospitals ordered. And we discovered that the residents had created like a sort of customized order set that they had saved as kind of the residency admission order set. And it had telemetry checked off by default. And so the only small tweak we made was we left telemetry on the order set, but we took the checkbox away so that it was not ordered by default. You had to click something to order it. And a lot of residents actually said, like, I thought I was supposed to order telemetry for all the patients. That was the standard of care at the Brigham, was every patient needed telemetry. And that was not the standard of care and not the goal. And so we had a huge decrease in the amount of telemetry that was being ordered, to the point where we were actually nervous. And so we looked to see if there were more kind of out of ICU cardiac arrests, or if people were then ordering telemetry on the second day or something like that. And none of that was happening. People were doing a good job of ordering it when they needed to. I do think that people tend to look at these order sets sometimes as kind of normative, right? Like if it's checked, that means I'm expected to do it. And if it's not checked, I'm not supposed to do it. So I think adding inline explanations of when you should or shouldn't do things is really helpful. I also find that people are really frustrated. One thing that I've seen before is something that says, like, if the patient's, over 65, then order this. If they're under 65, then order that. But it's just text, right? We should also then use some logic to check the thing that makes sense for the patient. And then if you think they're an especially spry 66-year-old or an especially sort of right out looking 50-year-old, you could switch it, but defaulting it the right way always makes people happier.
So I think you said something really fascinating there that I just want to touch on for a second, which is that choice architecture, which is one of the tools that we use to help engage people and encourage positive sorts of behaviors or discourage behaviors you don't want to see, is great.
Yeah.
But it really needs to be there combined with some kind of stakeholder engagement and education.
Absolutely. Yeah, I think some of the most interesting work I've seen on this is from Jeff Linder, who studies respiratory infections. You guys are probably familiar with this work, but he gave a talk that was so interesting. This is from behavioral economics. If you take a wine shop and you tell people that you organize it, so you've got the red wines on the right side and the white wines on the left side, and you tell people to pick two wines, they'll pick one red and one white. But if you put the international wines on one side, the domestic wines on the other side, tell people to pick two wines, they'll get one international, one domestic. So he knew that people wanted to quote unquote help patients that had upper respiratory infections, and the way they helped them was by prescribing inappropriate antibiotics. And so he created this order set that had so many medicines, right? Here's all your antitussive choices, here's all of your decongestant choices, here's all of your head pain choices, and here's all of your expectorant choices. And then you could really just load up the cart. You'd go through and click this and this and this and this. I'd give you so many prescriptions. I'm really taking your cold seriously or something. But what I didn't do was prescribe you an antibiotic. And I thought it was just a beautiful example of choice architecture.
I'm trying to think of something witty to say, and I've lost on that. So
we might be here a while.
Yeah, sorry about that. One thing that I hear a lot of people discussing when it comes to design and clinical decision support is the idea that you're never really done.
Yep.
And I think a lot of healthcare systems and hospitals kind of have that attitude of they get all those people in a room that you described earlier, and all the smart people, some of whom actually write orders in the electronic health record and take care of patients. And they come up with the plan and they institute the plan and they watch it work for 6 months based on criteria that they've developed before they instituted the plan. And it's terrific.
Yep.
And they think their job is done. And the department chair says, move on to the next thing. And sometimes that's a problem.
I think that's a huge problem. So I'll tell you that we'll be vague here, but I've worked at a large health system. I'm familiar with a large health system that had a policy that all the decision support had to be reviewed once a year. And the CDS team approached a leader in that hospital and said, we're too busy. We can't review the CDS that often. We want to postpone or possibly switch to a 2-year review period. And so that leader said, well, are we still still building new CDS? And they said, yeah, we have time for that. We should have time to maintain the existing CDS. And so that leader's response was, no, we don't have time to build new CDS, and we don't have time to maintain the existing CDS. One of the biggest predictors whether people are willing to accept new CDS is the experience they've had with old CDS. If you sort of let your old decision support rot, then your new CDS isn't going to work, as people sort of become just almost conditioned when they see a new pop-up or a new alert to just override it immediately because they know it's garbage. So some things that I found that work well are monitoring. So having tools to look at how much your decision support fires over time and how much it's accepted over time. If you have an alert that normally fires 20 times a day and now it fires 2,000 times a day, or it fired 0 times a day for the last 3 days, something might be wrong, and it's worth looking at that. And I actually got a grant at one point from the National Library of Medicine to do some of these monitoring things. But surprisingly, the most powerful tool that I found was actually user feedback. So it turns out that users want to tell us when CDS is working poorly, and even sometimes when it's working well for them. So here at Vanderbilt and also at Partners in Boston and other places, we have put these little smiley faces in the corner of all of our decision support tools, a frowny face, a smiley face, and sort of a medium in between face. And you can kind of basically upvote or downvote the CDS and leave comments. And the thing that blows people's minds is, I try to write back to their comments within a few hours. And so I got one over the weekend where we had this genomic decision support tool for APOL1, and it suggested urine microalbumin screening. The patient already had urine microalbumin screening. I looked at the chart, and this doctor was right. We had made an error in the decision support. And so I wrote back to her within 2 hours and said, I'm sorry, we have a new urine microalbumin test. It's not being properly picked up by this alert. You were right. The alert was wrong. I fixed the alert, and please keep the feedback coming. And so the thing is now first off, I solved her problem and she told me about a problem, but I bet she'll be more likely to send me feedback in the future, maybe a little more likely to read the alerts when I send them. And it's also just humanizing about it. I'm always amazed to learn that a lot of our users don't even realize that there are people at Vanderbilt that work on the EHR. They think that we bought Epic from Madison, Wisconsin, and it is what it is, and that there are 600 people at Vanderbilt working on it. It just blows their mind. And so, people occasionally write grumbly feedback, like, I hate this, you're so dumb, maybe a swear word or something. And then I write back to them like, oh, hi, it sounds like you're really frustrated. And they're very apologetic, but that's how you kind of win hearts and minds, I think, is by just responding to users. So I think the secret weapon to making your CDS better is user feedback. But I'm also a big believer in kind of reviewing guidelines over time and having good monitoring tools as well.
Yeah. So I am going to be talking with your undergraduate institution to see if we can get that math degree taken away, because what I'm hearing is that humans are important.
Yes.
And it's not just about the programming. The code can be great, but if you're not getting that feedback and then acting on that feedback in a timely fashion,
yes,
change that. If you really want to change hearts and minds, and often we do,
yep.
That's the way you do it. And you don't do it by developing a new module that can do something that people maybe haven't even asked for yet.
Well, don't worry, because I am a sort of unfeeling automaton. I actually used mathematics to build what we call a sentiment analyzer. So it reads the comments and it finds the especially grumpy comments and highlights them in yellow on the report. So I use mathematics to figure out what the users were really feeling. So I think I should be able to keep my degree.
I am so glad you said that, because I was halfway through the email.
Okay, good.
So I'm going to delete that email now.
Excellent.
Because I do have powers, and I didn't want to have to use them against you. But
I understand.
So Adam, how do you know when something you've created is ready for prime time? And what does prime time look like? Do you start at scale? Do you start with a pilot? You sort of touched on that a little bit earlier, but if we could kind of come back to that. And then when do you know when it's time to iterate and whether you're going to iterate on something or just sunset it?
Yeah. So my own philosophy is maybe a little bit controversial, but I'm a big believer in getting things out as early as possible. And so believe it or not, our CDS committee cares a lot about alert burden and reducing excessive firing of alerts and stuff like that. But I actually have a pretty low bar for putting out new decision support. As long as we convince ourselves, number one, that the thing is sort of clinically appropriate, as long as we have some sponsorship from the people that are actually going to experience it, right? So the classic example I use is when anesthesia comes and says, we want surgeons to do this thing, can you put something new, like a hard stop, to make sure the surgeons fill out this form before we get to the operating room or something? We send them back and we say, go find some surgeons physicians, get the head of surgery to come and co-present this with you, and then we'll turn it on for you. So we need some kind of clinical plausibility, agreement or kind of consent from the alerted or the supported in the decision support context. And then the third most important thing is a really clear evaluation plan. So I say, we're going to come up with this metric. We're going to say that we're going to improve this outcome by at least 20%, or we're going to improve documentation by 45%. The acceptance rate alert's got to be at least 50%. So we come up with some actual measurements and some agreed benchmarks for those. And then wherever possible, and I don't always win this, I prefer to do new decision support in a randomized trial. And so that can start small, right? We sort of do a step wedge thing where we just pick one pod of one clinic and turn it on for them and then sort of slowly work our way up. But I would actually say that I have a low bar for turning things on, but I have a high bar for evaluating them and then keeping them on. Our committee isn't great at picking which proposed CDS tool is actually going to work and which isn't. But we can do well is look at the data and then turn things off. And I would say this has worked really well for us, with one exception, which is sometimes things get this magical moniker called regulatory attached to them. Like, well, it's a regulatory issue that we pull Foley catheters. It's a regulatory issue that we go see patients that are on restraints. And it is a regulatory issue, don't get me wrong. But we have used that as an excuse sometimes to keep decision support on that has poor evidence for its effectiveness or even strong evidence for its ineffectiveness. And so that's the biggest sort of boogeyman that I've been trying to get rid of, is that this is a regulatory thing. I think if we really care about pulling Foley catheters on time and we have an alert that we know doesn't work, we're lying to ourselves, right? And we've done something. What we should do is turn the alert off and say, we have nothing. Y'all are on your own. And then we could sort of start from the drawing board and come back and build something more effective. But that's my take, is start fast, evaluate quickly. We sometimes iterate like multiple times in the same week. If an alert fires often enough, we can get feedback. We just had an alert for atrial fibrillation that we turned off and on twice in basically a week and a half long period, as we made little refinements to it and saw what was working and what wasn't working. So that's my philosophy, is I think we should turn them on fast.
That's great.
How do you sustain projects once the excitement's over? And I'm going to reference something that you just said, which to me seems like a brilliant idea. So you have CDS that's out there. You give people the ability to give you smiley faces or thumbs up, thumbs down, and to write some free text. And yep. I think in the literature that's been known as cranky comments.
Yes, sir.
And you said that you used math, and this is why I'm going to allow you to keep your bachelor's degree. You used math to identify those cranky comments, to call them out, and to make it easier, and I would argue maybe even exciting, to get that weekly or monthly report for whoever's looking at it. And that kind of keeps you going, because all the stuff that I don't really care about is not highlighted, and some of the things I really should care about is highlighted. Are there other tools or ideas that you have to kind of keep people, focused on the important things that they were focused on 6 months ago?
Yeah, this is a really interesting question, right? So we get a lot. This is a teaching hospital. We get a lot of excited trainees and fellows that come through with a specific idea, and they're so passionate about it. They build it really diligently, and it's great, and they get people to use it, and then they graduate or they move on to something else or start another project. And so I think that energy is incredibly important. We try to capture and harness that energy and point it in the right direction whenever we can. But there is also kind of a almost sort of slow going kind of diligence that's required, to work on the other 840 alerts we have and make sure they're working in our 2,000 order sets to make sure that they're good. And so I have found, honestly, that there are just some people who have the temperament for it. Atul Gawande wrote this paper about primary care, right? He's a surgeon, and he was talking about the kind of power and beauty of going in and cutting out someone's gland and seeing their disease get better. And then he talked to his friend, Asaf Bitan, who's a primary care doctor, and he's sort of slowly chipping away at people's LDL and hypertension and get him to quit smoking. And, who's really saving the patient, right? Is it the surgeon that does this kind of flashy thing, or is it the person that meets with the patient 12 times over 5 years and gets them to quit smoking and start taking antihypertensive? And so I think there are some people who are cut out to be primary care doctors and some people who are cut out to be surgeons. And I think I have the same thing on my CDS team. I have some people. I was talking to one of my most diligent colleagues, and he said, look, over the last 2 years, I've improved the acceptance rate for the medication alerts 1% 30 times. And so none of those was exciting or, really that impactful. But when he just used this approach to chip another percent off, now he got to 30%. And it's uncommon that I could make a single change to a decision support tool that improves at 30%. So I think you need both kinds of people. And I actually think that the people who are doing the slow work really benefit from feedback and data, right? So I make a point once a year, we look at our firing rates, our acceptance rates, and I just say, look at what we've accomplished. It was slow, but we sort of knocked these things off, and now we're 20% better than we were a year ago. And, I focused a lot on the cranky comments, but believe it or not, people actually click on decision support alerts and say, thank you, this helped me. I hadn't thought of this. This was well timed. And so we make sure that we get those right to the people that have been involved in the work. And I also find, as people have been working remotely or working from home or something, some people have almost lost their connection to the clinicians. And so we try to bring our team in as much as we can to round with people or talk to users. And honestly, just hearing a user say something like, I feel like Epic's a little less annoying now than it was a year ago. That creates some excitement and energy to keep things going. So I think that to me has been the key, is just being able to see the process, right? You're not Sisyphus, it's not like just keeps rolling down the hill, right? You are slowly getting the rock up to the top. It's just taking you a little while.
That was great, Adam. Thanks so much. One question we like to ask everybody towards the end is to just have a think about 3 things that you interact with on a regular basis that are so well designed that they bring you joy. And they could be things outside of healthcare.
Absolutely. Okay. So the first one is actually one that I interact with primarily with my kids. I have 3 kids and one more on the way. And we bought this thing. I thought it was the dumbest thing I've ever purchased. It's called a Nugget. It's a play couch. And it's basically a couple pieces of rectangular foam and a couple pieces of triangular foam. You can build a couch out of it. And my kids have so many toys. They're electronic toys and digital toys and stuff. But they just scream and fight with each other over who could take the Nugget and build a fort out of it or something. I don't know how the Nugget people figured it out, but it's just the perfect size and the perfect number of pieces. We just bought another Nugget because there was so much fighting. So when the kids get really aggressive, Grace gets the red Nugget and Isaac gets the brown Nugget and they play alone. But they have built forts. They've built towers. They built a ladder. Isaac made a booby trap this weekend, made a podium and give speeches. They've made stages to play on. It's just genius. It's literally, it's $300. It's ridiculously expensive for a piece of foam with some fabric on it, but it's my kid's favorite toy, and I should just throw their other toys away and get it. So whoever designed that is a genius. The second one, I live in the South, so I will say is the Chick-fil-A mobile app. So people here really like Chick-fil-A, and so many restaurant apps kind of break down quickly, right? So if you want to get a free glass of water, or if you want to order on your phone but dine in, or if you want no ketchup on your hamburger, they just don't work or something. And Chick-fil-A's mobile app is beautiful. It everything works correctly. It handles exceptions well. It's pleasant to use. The other day I got an alert that, I had placed an order and I had actually accumulated enough rewards that they could make, this broccoli side dish I ordered free. And so they didn't have to proactively tell me that. I probably would have just let my reward expire because I wasn't paying attention, but I felt like they were helping me with that alert. So I think that's a beautiful thing. And then the third one, I feel like these examples I'm giving you make you sound a little bit sort of like a man of leisure on a play couch eating Chick-fil-A or whatever, but it's actually my hammock. So I have this Brazilian hammock that I got, and I don't know how they made it, but it's just sort of, it's so comfortable. You sit in it, you just kind of feel like you're floating in the air. It's exactly the right length. It's just comfortable. You get in it, you don't even feel like it's there. You're kind of swinging in the breeze. And it's the one place I can sort of get in and just stop thinking about things and just relax or whatever. So I would say my Nugget play couch, the Chick-fil-A mobile app, and my hammock. I should have picked a fitness-oriented thing or something, but those are my 3.
Those are great. And as the parent of 4 children, I will counsel you later. We'll do that offline. Okay. And I'll give you advice, mostly tax advice.
I'm going to need it.
Well, thank you so much. This was great. We really appreciate your learnings and your experience. And I do want to officially apologize for threatening to have one of your undergraduate degrees removed. That was a mistake, and I won't repeat that.
Thanks, Greg. The privilege to be here. I had a lot of fun, and I look forward to the next conversation.
Awesome. Thank you again. Thanks for tuning in. We hope you enjoyed today's episode. For more information on Dr. Wright's work, check out the Vanderbilt Clinical Informatics Center at vumc.org/VCLIC.
Check back for more episodes of Designing for Health wherever you listen to podcasts or on NordicGlobal.com. Till next time, we'll see you in network. If you enjoyed this episode, please leave us a 5-star rating and a review. This helps others find the podcast as well.